Oh, hey, Dr. Lynn.
Recording in progress. Recording in progress. Recording in progress.
Hello.
Hey everyone, can you hear me?
Yeah.
Oh, okay. This is the first time using my desktop. I'm not sure if the sound actually works. Okay, so it's fun. So I have a disclaimer. I tried using the good notes to read the journal article. It's actually really good on the iPad because you can actually write directly on your iPad. Right. So I have the articles and then I can literally just directly write on it and then it just kind of annotates directly on it.
Can you make like little boxes that will pop up at all, or is it all the same sizes?
No, so for instance, I have these where you can just basically it's exactly like when you're doing it on paper.
I think Dr. Chapman's rocking out.
Yeah, I feel like it too.
All right.
My radio's off, so I'm going to be playing the Rolling Stones, not that stuff.
All right, let's get started. Fred, you want to do yours first?
Sure, I'll kick things off. So I did 2 articles. We'll start with the easier article just to kind of get everybody warmed up. The influence of universal face mask use on endoplamidis risk after intravitreal anti-VEGF injection. So this was kind of an interesting article that we were in a very interesting time with COVID over the last 2 years. So basically the outbreak of the coronavirus forced patients and physicians into routine mask wearing for all injections. So the authors of this article wanted to look at, does this have any effect on post-injection endoplamidis? Does the mask reduce airborne flora to actually reduce risk? Does it create a jet stream by where the top of the mask allows the bacteria to go right into the eyes? Or does it have no effect ultimately? So this was a retrospective study that was conducted from the end of 2019 into mid-2020 that looked at nearly just over 500,000 intravitreal injections of anti-VEGF administered to over 110,000 eyes at 12 centers. Steroids and brolucizumab were excluded. And it was basically broken up into 2 groups, and one group had a little subgroup, which is actually partly what we do at Kresge and Dr. Abrams' clinic. So there's the universal face mask group where physicians and ancillary staff wore a face mask, the patient wore a face mask, but this was kind of, all face masks were of the physician and patient's own choosing. There was a small cohort here where the patients had the top of their mask taped prior to injections. And then there was the no face mask group, which was before COVID, and physicians and patients did not wear face masks. So out of the nearly 500,000 injections, 130 cases of presumed endophthalmitis were identified. The rates of presumed endophthalmitis in the no face mask group was about 1 in 3,500. The rate in the universal face mask group was about 1 in 4,700. And then if you look at the, if you break the data down just a little bit more and look at the patients who had their nose taped for the injection, again, it was about 1 in 4,650. So similar to the rate of the universal face mask group. And then essentially between these two groups, there was no statistically significant difference. When you went a little further and you looked at, instead of presumed endophthalmitis, for culture positive endophthalmitis, the rates for the no face mask group was about 1 in 10,000 versus the universal face mask group was about 1 in 24,000, 23,000. So actually there was a significant difference in the rates of culture positive endophthalmitis. When they looked at oral flora, there was no difference in oral flora between any of the groups. Conclusions is based
We're losing you.
on endophthalmitis. There was. Am I back? Hello?
Yeah, we can hear you now.
Okay. For some reason, it said my internet is unstable, but I'm back again. Basically, for presumed endophthalmitis, there didn't seem to be much of a statistically significant difference. Maybe if the study was powered a little bit more, they talked about, maybe if you had closer to 2 million injections, some of these numbers may have become statistically significant. But there was a rate and difference of culture positive endophthalmitis. There's no difference in oral flora associated with endophthalmitis. There's no difference between drugs, and the visual acuities in the two groups ultimately ended up being the same. And there wasn't too much of a difference between taping the mask and not taping the mask for the patients who were wearing masks. Big limit of the study is obviously it was retrospective. All the records were pulled based on CBT billions, which makes it difficult. There's no universal face mask, and also there could be this idea that the infection control just got better when there was coronavirus. All the services were now being wiped down. Everyone was wearing face masks. Everyone was sanitizing their hands, multiple times a day. Everyone became more conscious of infection control. So that could have also been kind of a limiting effect of the study. But ultimately, I thought it was kind of an interesting thing to look at. Coronavirus provided a unique time to look at it.
What does everybody do here? What do the other people do here?
Well, this is Patrick. I actually look at their lids and lashes. I do universal face mask, and I actually do a little wheel of xylocaine and put the injection through the wheel of xylocaine. So I've got a little barrier, and I've been very uniquely successful with those opportunities. Now, I'm very, very old-fashioned. I possibly am wrong, but I do put people on antibiotics also. But I've had no culture positive endophthalmitis.
I've not only had no culture positive endophthalmitis, I've never had an endophthalmitis. So.
Okay. I mean, I've had one inflammation from Avastin, but that's all I've ever had.
Yeah.
Do
you tape the top of the mask?
Yes.
Yeah, I do too. Is everybody taping the top of the mask or not?
I have not taped the top of the mask. I tell them don't breathe when I'm injecting, but Well, between my last betadine drop and injection, I tell them to don't take deep breath. I haven't taped the top of the mask. Is it a standard? A lot of people tape the top of the mask.
I always do.
In
Even
this
COVID,
study,
you mean?
Frankly, I like the top of the mask taped during the examination that keeps my lenses. from
Yeah,
fogging.
yeah, I like that.
So, you know,
in
ideally,
this,
they top the tape of the mask, tape the top of the mask when the patient arrives. And if we inject them, it's already taped and we're ready to go.
Does anybody do a wheel of xylocaine like I do? I mean, I use the regular gel and betadine, but I make a little elevation in the bulbar conjunctiva and then go through that.
You know,
Yeah, I
Patrick,
do
I
that.
just use topical. I just use topical proparacaine.
Okay.
I put it on directly on the conj with a Q-tip several times. You know, and then, you know, the gel. It's been shown to potentially increase the risk of endophthalmitis by potentially preventing the betadine from getting onto the surface. So I've never used gel. I know a lot of people do. I've just never. When I read that, I said I'm never going to use gel. I used to use lidocaine, a mixture of lidocaine and proparacaine, and then you know I think the lidocaine dripped on the eyes causes a lot of keratitis, so I stopped using that. I just use proparacaine. If you wait 15 minutes, they've got great anesthesia. If you try to go at 14 minutes instead of 15 minutes, they feel it still. And if you look at the pharmacology of proparacaine, it takes 15 minutes for full effect. So, you know, we always check the time when we start the drops, and then we wait at least 15 minutes before we give the injection. They're pretty. I don't know, the fellows. What do you think, Brett? I mean, they seem to be pretty comfortable, don't they?
yeah, most people seem to do pretty well. I'll be honest, I personally prefer subconj lido.
Yeah.
I think then the patient literally feels nothing. And I think it works a little bit faster. But if you sit there and you do a Q-tip for, you know, a minute twice, you do give them the full 15 minutes. I truly do think it works pretty well. But they tend to still, like, patients will still kind of twitch when you do the injection. A lot of times if I do subconj lido, the patient's like, oh, we're done.
Yeah, so
and they kind of don't feel it at all.
Yeah.
yeah,
Well,
my
you know,
mom actually gave me the firsthand experience or firsthand feedback. So you know, when she goes back to China, they do just topicals and then they give her the shot. So I always do a subconj lidocaine, and then I give it about 5 minutes or so, and then I do my normal prep and I give her the shot. She could not believe I gave her the shot. But I mean, sometimes she sees bubble, but there's absolutely no recognition that a shot was given.
See, she just trusts you. I think that's it.
No, man. No, I actually, there's a lot of these, I guess some of the VA ones that I don't know why that after here, you know, if you put the subconj, give it enough time, it's pretty consistent that most people did not know you gave the shot.
Well, you know, try as I may to miss the conjunctival vessels. I mean, every once in a while I nick a conjunctival vessel and I end up with this huge hematoma that lasts about 10 days.
Yeah.
And the patients hate me afterwards if they get a hematoma. So that's when I pretty much stopped giving subconj. You know, I had a couple of patients with big hematomas and I said, to hell with this, I'm finished. But, you know, one thing about injections, everybody thinks their way of doing it is the best way. And that seems to be, that just seems to be the way it goes. And everybody's got their favorite way of doing it. And as long as they're not getting endophthalmitis, I think it's great. The only thing, I'm a strong believer in a speculum. I just think you ought to use a speculum. But, you know, to each his own.
Do you guys do anything different with the Ozurdex versus when you do your anti-VEGF in terms of your prep, your
I use subconj for Ozurdex.
oh yeah. Besides that, like in terms of the betadine,
I think it helps
mean,
displace. I also think if you have the subconj, it helps displace the conjunctiva to protect the wound a little bit. And those wounds are so big with Ozurdex.
I just, you know, I just get real nervous with Ozurdex, so I end up putting a lot more betadine before, and then after I inject, I put some more betadine on the surface. That big leaking wound, they're always low pressure after you inject them.
Right. Have you given one in a post vitrectomy eye?
Well, I heard you had one that became a raisin.
I had one that the eye literally collapsed. So, you know, I knew how to manage that. I quickly covered it with a patch so I couldn't see it. And had her back the next day, and it was, eye was formed and she was fine. But I was sure I'd destroyed the eye.
All right, in the interest of time, let's go to Brett, you have a second?
Yeah, I have a second article, a little bit more interesting. Let me get it open here. So the second article that I did, oh, sorry.
Which one? Which one we doing?
The article is the Philly. Characterization of new onset exudation in the Philly trial for pegcetacoplan. What is pegcetacoplan? I may or may not even be saying it right, but let's start there. It's a new medication. It's a new complement C3 cleavage inhibitor that has shown efficacy in reducing the rate of geographic atrophy lesions by about 30% when dosed every 1 to 2 months over a year. And so that was the setup for the Philly trial. And it's essentially the first medication to slow progression of geographic atrophy over time. So where did this article come from? So this article stemmed from the fact that in the Philly trial, a higher incidence of new onset exudative AMD occurred in treated eyes than eyes that were treated with sham. At the end of the 18 sorry,
didn't lampalizumab show decreased progression in phase 2 also? Or was it just in certain subgroups?
In phase 2, it did. Phase 3, it completely flamed out.
Yeah, that was it.
That's what's going to happen to this one too, I predict.
Yeah,
we'll keep going, Brian.
That's fair. RIP to pegcetacoplan before phase 3. So the phase 2 trial was done over 18 months, 12 months of treatment followed by 6 months of monitoring. For the eyes that were treated monthly, there was a 21% rate of conversion to exudative AMD. For the eyes that were treated every other month, there was a 9% conversion rate to exudative AMD. And for the eyes receiving sham, there was a 1% conversion of exudative AMD. So those are obviously some pretty high numbers. 1 in 5 patients that were treated monthly were developing exudative AMD compared to otherwise 1 in 100. So they looked at the post hoc analysis of Philly in this study. So this study looked at 246 patients that were enrolled in Philly were enrolled in Philly with non-exudative AMD. So the progression to exudative AMD over the whole study was seen in 26 eyes across the 3 treatment groups. They tried to characterize high risk patients that would be at high risk for developing exudative AMD. Were there any associations? The 2 associations that they found was if the patient had exudative AMD in the fellow eye. Of those, roughly 70% developed exudative AMD. I misspoke. Of the eyes that developed exudative AMD, roughly 70% had exudative AMD in the other eye versus 35% in the study eyes. The other thing that they noticed was the double layer sign. Basically, a double layer sign is a low-lying PED, which can indicate a low-lying fibrovascular membrane between the RPE and Brooks membrane. They gave a good example of this in Figure 1 for our residents here. Basically, it's just kind of just a low-lying PED that can represent a early fibrovascular membrane that's splitting the layers of the RPE and Brooks membrane. Again, in the study eyes, there's about a 70% association with the double layer sign in those that developed exudative AMD versus about 30% in the other study eyes. And actually, mean time to progression to exudative AMD was fairly a long time. It was roughly 250 days. And if we look at figure 2, it seems to be kind of a dose-dependent effect, whereas the monthly dosing group developed it, earlier than the every other month dosing group, and it seemed to be much higher incidence kind of over time, like I said, with mean time to progression of roughly 250 days. They did note that patients that developed exudative AMD did not have an impact on visual acuity, and that all patients responded well to anti-VEGF. So kind of in conclusion, pegcetacoplan did work as intended in slowing the rate of geographic atrophy in this phase 2 study, but it was associated with a dose-dependent incidence of exudative AMD. So kind of some of my takeaways was that obviously if this medicine ever comes to market, you need to be very careful, if the other eye is exudative AMD, or if you kind of see these double layer signs. A couple ways to help investigate that is using an OCTA or CGFA may be able to help kind of these double lines do have true exudative qualities. And something else I kind of wanted to talk about really quick with this medicine is kind of the risk-benefit ratio. I mean, this medicine is dosed. You're doing an intravitreal injection every 1 to 2 months for a medicine that moderately slows progression of geographic atrophy and has a high risk of developing exudative AMD. I'm just not sure how I feel about a monthly intravitreal injection. I mean, maybe if there's geographic atrophy that's sitting, microns from the center of the fovea, the benefit analysis may be there. But it seems like a relatively risky medicine otherwise.
Dr. Abrams, how does this get through the data safety monitoring committee?
Well, I think that, it was a fairly large study. I mean, this is a select group out of a very large group. So, Brett, what was the total number of eyes?
I think it was like 250.
Yeah.
Yeah, that's right.
You're looking at a relatively small number of eyes among that. And then I think it's interesting that they found these risk factors that really made it, where you could identify the ones most likely to get it. The double layer sign and the CNV in the other eye. So I suspect that they identified there was an issue, but they decided it wasn't severe enough to intervene.
Yeah, what's interesting is
the visual acuity they did not find, even in these eyes that developed CNV. Exudative changes, there was no difference in visual acuity in that group versus the rest of the eyes. So that's
the other company that
go ahead.
Can you hear me?
Yeah.
The other company that Glenn Jaffe's working on, the C5 complement inhibitor, they also saw an increased incidence, 10% versus 3% in the sham. Not quite as many in this study, but it seems to be for the other drugs as well. So
interesting. I didn't know that. So that's a C5 inhibitor. This is a C3 inhibitor. So.
Correct. Yeah.
If you look at the subgroups, so if you look at table 2, all the groups, even the ones with the risk factors, the sham arm doesn't really have that much CNV. Like if you look at, if you look at table 2, the ones with double layer sign, the treatment group has like 30%, 24% CMV. The sham group is like 4%. Even if you match up all the groups, you know, or the ones that has where the fellow eyes had a exudative AMD, the sham group or the sham group didn't really have that many CMVMs. It's only in the treatment groups.
Yeah, it seemed like the treatment group had more severe disease to begin with.
Yeah, they do
randomization.
So the first one, so if they have more severe disease, then that the study is not even, I don't think it's even valid because it's not balanced anymore. But I suspect that the first column on table 2, the 47%, 33%, 29%, I suspect that's probably when you do the statistic, that's not actually statistically different, so that the 3 groups are not, it just looks like there's a little more. But then when you look at within each group, whether they have risk factor or they don't have risk factor, all of them, the treatment groups are much higher CMV. So my feeling is this is a real thing. The medicine causes CMVMs. And maybe you follow it longer, they end up having a visual acuity drop. My takeaway from this was saying, the reason you're getting CMVMs in this drug group is because there's higher proportion of them that already had a cult CMVM that you're not noticing. But the data is showing that regardless, even if you look at the ones that had a cult CMVM, the control one doesn't end up exudating, only the treatment one does.
How, CC and Chris, I don't know if Deep is here or not, but have people seen, how useful have you found OCTA in identifying this non-exudative neovascularization?
Gary, I haven't found it useful yet, but a few months ago I read a paper by Shen and Joseph Rosenfeld at Bascom Palmer. It's this University of Washington group. And it's a pretty good paper in investigative ophthalmology showing their lesions. And they looked at things like the vessel skeleton density and the size of the PEDs and a bunch of other parameters. And so I'm going to start using their data. Interestingly, they found out that the smaller the lesions, the smaller the PEDs, and the less the capillary density, the more likely they were to have these membranes. So I'm still open-minded about it. I'm just
question, Chris. Were they using SDOCT or swept source OCT?
Swept source.
Yeah. Okay. At Bascom Palmer, they've got this Plex Elite 9000 that they use for this. And I've talked with Dan Martin and several people about this. And swept source, you can see the choroidal neovascularization quite well. With SD, it's patchy. Some patients you can see it, and I've had a few that I've seen it, but I find usually the scans just aren't clear cut.
Yeah, the one thing they did
that source, it's much better. And so I wish, I wish we had that. They may yet still get the swept source, over at labor and delivery, because that's still that is not dead yet. Apparently,
one interesting thing that they talked about was when they identified multifocal areas, it was much worse in terms of these occult or non-exudative membranes growing, and so it's caused me to give me pause to go back and look at things maybe more carefully, even though we don't have that level of resolution, But.
So anyway, there's a high risk of progression to exudative in those eyes. I think 14% or something like that over a year or two.
Yeah, I thought it's almost 20%. Yeah, but pretty high.
Yeah. Anyway, I've just not, I've been getting OCTA on a lot of these eyes, and it's patchy. Occasionally I have been successful in seeing the non-exudative choroidal neovascularization, but usually I'm not very successful with it. And I think it's the imaging modality we're using is the big problem. But I like this. I've seen, the double layer sign. I really hadn't been paying any attention to that. I mean, we see so many of these patients with geographic atrophy or some degree of geographic atrophy that have this double layer sign, and I had not paid that much attention to it. I mean, you knew it was, but I think that's what probably the best thing I got out of this paper is this double layer sign. Patrick, you been using that? I guess Patrick's left us. How about you, CC and Chris?
Yeah, I've always been paying it for a while. I've been paying attention to a double layer sign. I mean, I just watch them closer. I knew there was probably a presumed hidden net in there.
Yeah. The double layer sign, I mean, I watch for it now since I came to Kresge, especially with polypoidal, because you get the double layer sign in polypoidal and in these selected lesions. And but I think I'm going to look more carefully at the hyper reflectivity within the PEDs as well. Spend a little more time looking at those small details. So.
Well, it's interesting. I'm for sure I'm going to pay attention to that from now on. I think that's the best thing I got out of this paper.
How frequently do you see those patients? Like if they've been stable without exudation for a long time, but they have this double layer, do you see them like every 2 months? How frequently do you see those patients?
Well, I got this lady, Mrs. Shamami, who I follow probably every 2 months.
Yeah.
Who has bilateral double layer signs, and she recurs, every few months, and finding the right time to treat an extender is very difficult because of she's got, she doesn't follow just a single timeline like some people do. She's variable. There were times I could go 4 months without an injection on her and she'd be just fine. But then the next time she'll recur in about a month. So I've gotten her back right now to every, 4 to 6 weeks injections in each eye. So
Gary, do you have her on Eylea?
yes.
Okay.
Yeah, it's interesting you mentioned these. I've been noticing more and more of these inconsistent timeline kind of wet AMD.
Has anybody treated anybody with Bizumab yet?
Nope.
I'm
actually afraid to use it.
I don't think that have they actually distributed it yet?
I thought they did. With that brolucizumab issue, I was going to wait till people done plenty of it before.
I'm not anxious to jump ahead and use it either, but some of these patients where you're having to inject them so frequently, if this does last a little longer, that would be ideal.
Yeah.
Anyway, this is good. This is an interesting paper. I enjoyed this paper. I think it's going to be interesting to see how the further trials geographic atrophy turn out. The phase 3 trials.
Gary, are we saying that the onion layer sign is the same as the double layer sign?
I don't know.
What
do you think?
I think so, but I've heard it both ways. I just wondered, you have more friends in high places. Are they saying onion layer or are they saying double layer?
My friends in high places, they refuse to talk to me. So
well, okay.
Actually, I've got friends in low places.
Well, I've been listening. I mean, I've been part of this Unuzi group, and they're calling most of these things an onion layer sign, but
Yeah, I think it must be the same thing, isn't it?
Okay.
I don't know.
Okay. All right.
If Newsy says it, it's probably true. So.
Okay.
All right. Chinwe, you want to do yours?
So I looked at the Peachtree, so I had to as well. The first, let's go over the Peachtree study. So this is a study looking at suprachoroidal triamcinolone in patients with non-infectious uveitis complicated by macular edema. So it's a phase 3 randomized trial, and it was the purpose of the study was to review the efficacy and the safety of suprachoroidal triamcinolone. So as we know for uveitis, steroid is so helpful in treating our inflammation, but it often causes things like pressure increase and cataract formation. So the thought is that perhaps suprachoroidal triamcinolone can prevent some of these adverse events like cataracts and IOP increase. So the study looked at 160 patients with non-infectious uveitis and with macular edema. And the patients had to have an IOP of 22 or less, or be on 2 IOP lowering medications or less. They were randomized 3-2. Some got suprachoroidal triamcinolone, the others got sham. And the patients, the primary endpoint was improvement of 15 or more ETDRS letters at week 24, or reduction in their central subfield thickness at week 24. The patients were able to stay on 20 milligrams a day of prednisone or their IMT, whatever IMT they had. And at week 4, they could be rescued if needed. And so that was kind of left to the physician's discretion. If they felt like vision was decreasing, they weren't making improvement, they could be rescued. So the results of the study, at 24 weeks, about 45% of the patients with suprachoroidal triamcinolone had a gain of 15 or more letters, ETDRS letters, versus 16% in the control. The mean change in CST was 153 microns for the triamcinolone arm versus 18 in the control. There were no real serious adverse effects, and there was an increase in IOP in 11.5% of the patients with triamcinolone versus 15.6 in the control. The cataract formation was about equal, with 7.3% in the triamcinolone arm and 6.5% in the control. And so I think the suprachoroidal space is very interesting. I think it's really exciting. And I think in the future, hopefully it will give us another way to treat patients, especially patients with like chronic macular edema. It's shown that folks who receive suprachoroidal triamcinolone, they can have up to 3+ months of treatment from this. And so I think it's exciting. I mean, I think that some of the interesting, I wish that there was another leg of the study that showed like intravitreal triamcinolone or like PSTK or something like that, so that we could compare, because I mean it's nice to see versus sham, but you know, it's all the things that we expect, that steroid versus no steroid, you'll have a better response with steroid. And then I think it's kind of interesting that the patients were able to stay on like 20 milligrams of prednisone. That's a lot of prednisone, and they were able to stay on their IMT. So I think that was a little interesting, and you know, I wish they went into a little more detail. And also, the study did look at folks with all types of uveitis. I wish they went into a little more detail about like the pan versus posterior versus interior uveitis. So, but I think it's promising.
Well,
See any?
who has experience in using this?
I have one. I did one.
So you,
That's it.
CC, Dr. Lin has vast experience, case after case after case. He's done his one case.
I have
So-
my one case. It wasn't easy. I think Brett and Jim were with me. Was it?
I just
Or-
heard the patient scream from down the hall.
It was not.
Yeah, it was
easy.
myself,
was
it
it
was,
painful?
myself and Sharmella. Yeah.
Yeah. Oh, yeah. It was not easy to get it in. what happens? No, I mean, it's not the getting through the sclera. It's when that, well, getting through the sclera is not easy either. On the demo eye, it looks so easy. You just push on it, and then basically that short needle, you won't get into suprachoroidal space until you indent the eye a certain degree. On the model eye, it seems so easy. You just push on it while you're pushing the plunger, and the plunger won't push until you're past the, sclera basically. And then once you pass the sclera, it starts releasing. But we used the original needle, couldn't do it. Used the long needle, tried a couple times. It just won't go until you push. At some point, it finally went, and then that's when they started screaming because it's dissecting through the suprachoroidal space. It doesn't make
You
like.
thought it was because, I think you
It's a
didn't say
suprachoroidal.
that you thought it's because that there was this rapid expansion.
Yep. It's not the penetrating sclera. He had subconj. The actual needle poking through the sclera, he didn't actually feel anything. It was the actual medicine expanding in the suprachoroidal space.
How
I think
slow
what
did you?
well, the problem is they tell you to go really slow, but you have to put pressure on it to know that you're through. So you're pushing on this plunger and you're pushing on the eye at the same time, and it's not going through. And then suddenly, finally, when it goes through, there's a jerk of a bunch of medicine that goes in, and then you try to slow down, but they're already screaming. Then you just want to kind of get.
How far posterior do you go, CC?
They say 4 millimeters, same as
4
Intervitial.
millimeters?
Yeah, I assume they're worried about that you poking through all the way. I figured it. So that's why right there, I guess if you poke it through all the way, you could be through pars plana. That's my assumption. Why 4 millimeters?
Well, they had one. I think didn't they have one retinal detachment? But it was weeks after the injection. Probably
They said it was unrelated though. Yeah, or they thought it was
associated with PVD.
I asked them a lot about. I thought they would have more suprachoroidal hemorrhage and or a vitreous hemorrhage, or like the triamcinolone just injecting into the vitreous instead. But they went through their data. They said really there wasn't any, especially suprachoroidal hemorrhage. There wasn't any.
One thing that I found really interesting here, and now thinking about it, I remember the person who did the preclinical work on this and had the idea and did the preclinical work on it was a guy named Henry Edelhauser. And Dr. Edelhauser was my mentor at the Medical College of Wisconsin for the research I did on both SF6 and C3F8 gas, as well as the increased glucose to prevent cataract during diabetic vitrectomy. Hank, after he left, Dr. Edelhauser, after he left the Medical College of Wisconsin, went to Emory with Tom Auberg. Tom Auberg left Milwaukee and became the chair at Emory. And he brought Henry with him as the director of research. And I remember going down there and touring Hank's lab when I went down there as visiting professor. And Hank was telling me all about this amazing technique he had developed for suprachoroidal steroid injection. And he was looking at the steroid distribution in the eye and a bunch of things. So he did the preclinical work on it. And unfortunately, Hank died probably 6-7 years ago, unfortunately. So he did the preclinical work, but he's going to get none of the glory. So
my impression is once you put this in, it's actually a pretty diffuse distribution in your suprachoroidal space. In my mind, I thought it would be like, a suprachoroidal hemorrhage. It comes from one place and you get one giant bulb, but it seems like it's supposed to be diffused all the way around.
yeah. So it's, I think it's interesting. Fortunately, I've got Dr. Lynn, he'll be able to give these, and I'm sure he'll be happy to give more and more of these.
It's easier to, and maybe it's the first one, but I don't know if it's more traumatic for him or more traumatic for me. Probably more traumatic for him, but it's pretty traumatic for me. I mean, I wish it was easier.
So let's say, have you heard anything out of anybody else in the either CC or Chinwei? Either have you heard anything more out of the uveitis community, or people really taking this on and starting to do it, or is there significant hesitation among the community?
I haven't heard anything. That I've heard mostly from Dr. Lynn. We've done a lot of suprachoroidal things lately, but I haven't really heard in the community. I mean, I don't know how much it compares to other more comfortable ways of giving steroid. And so, I mean, I think folks are still comfortable with their Ozurdex and PSTK and different things. And so I think in the future, it'll be interesting to see how it compares to other modes of local steroid.
What we've tried is it hurts so much in the clinic. So some of the post-surgical uveitis, we do a small, how we do a cut down for a drain for in the scleral buckle. So we do a tiny dissection to the suprachoroidal space, put a little glob of viscoelastic and put triamcinolone on the blunt cannula into the suprachoroidal space and then give it. It's hard to tell if it works because there's so much post-op steroid. I don't know if it's the suprachoroidal steroid that's working or the post-op steroid, subconjudex. But we do a tiny scleral dissection and put the suprachoroidal there. But I haven't heard from any uveitis. I mean, the main uveitis person I know is Chinwei, so otherwise I haven't heard much.
Yeah, I don't think I'll be doing one anytime soon. So,
Well, it'll be interesting to see what the next American Uveitis Society meeting, how much this is taken off.
So the next paper I had was the early PPV for proliferative diabetic retinopathy. And this paper kind of discussed the burden, like we all know very well, of diabetes in the eye and with diabetic disease and ways that diabetic disease are the ways the diabetic disease is approached now. And this was a retrospective review that looked at about 120 eyes with PDR. And the authors felt that diabetes should be looked at as either patients with full PVD or patients with no or incomplete PVD, and then the folks with a full PVD versus those with no PVD should be treated differently and should be approached differently. And currently, PRP is like a gold standard for PDR. A combination of PRP with anti-VEGF. The authors fear that this approach doesn't work well for folks who have not had a PVD, who have not had complete PVD, and that over time they often need a large percentage often need additional PRP. If they're lost to follow up, they come back with even more severe disease. And so they are advocating for early vitrectomy in folks who do not have a complete PVD, so that so patients can undergo vitrectomy with PRP. And they feel that stabilizes the eye, and it gives better long-term success. And for patients who are older or who've had complete PVDs, they can continue receiving standard treatment with PRP and anti-VEGF. I thought it's really interesting. I mean, I think this is a conversation I've had a few times with different attendings, kind of like when is too early, when is too late. I think that this is like a great discussion. I wish they kind of specified more, like when is early. They said they mentioned patients with severe NPDR and PDR, because the same vein, if you go into an eye with severe NPDR, that's 20/40, and then you approach the TRD, there's a high risk of making things worse. And so it'd be kind of interesting to know when they felt like going in, when they wanted to go in for these folks. I know Dr. Yoganathan, I've discussed this with her. She kind of feels that early PPV is the way to go. So I just thought it was really interesting.
This argument's been going on clear back to the diabetic retinopathy vitrectomy study. They found a benefit of early vitrectomy in young diabetics with vitreous hemorrhage, and that was the only group that they found positive findings in. But that was back a long time ago, as before endolaser. I think endolaser was invented during the study, and they'd never incorporated it in the study. So, which obviously endolaser changed everything with vitrectomy. But I remember after that came out, Steve Charles wrote an editorial, or actually his letter to the editor about the paper. And he emphasized the high rate of no light perception vision that they had within that group with the early vitrectomy. And he argued vociferously against it. And of course, it was a different day. And I think there's no question with small gauge vitrectomy, endolaser, new cutting techniques, the way we now do vitrectomy and all that, it's much, much, much safer than it was back then. But, at the same time, I'm not sure, one thing, this was published in Current Opinion in Ophthalmology. And this is an opinion. This is not fact-based, it's an opinion. And he based on anecdotal, her clinical impression. And yeah, she cites some papers, but I don't think the papers are all that strong. And I'm not sure this would stand up to a randomized controlled clinical trial. It'd be interesting to see, but I don't think it's going to happen. There's other studies that have shown that, you've got eyes, if you do vitrectomy in eyes with traction detachments and you do them without vitrectomy without PRP, pre-op versus doing them after PRP pre-op, you find that the eyes that do better that have had PRP preoperatively. So, I had the sense she was advocating early vitrectomy in these eyes and then doing probably the laser at the time of surgery. She didn't specifically say that, but that's sort of the impression I got from the article. So, that flies against some of the other studies that have been out there. So, I've got my doubts if this would stand up to a randomized controlled clinical trial. All of this is people's current opinions, just as the name of the journal is. So, I think a little less certainty in this is probably warranted. I'd be interested in other people's opinions on this, because obviously we're talking about current opinions.
Good question, actually, along those lines. So Dr. Chapman and I actually just had a patient, a 28-year-old diabetic type 1 for many years, uncontrolled PDR. The right eye had developed some pre-retinal heme in the mid-periphery, not involving the macula at all. He had some fibrovascular membrane superiorly and inferiorly outside the arcades, So underwent several sessions of PRP, good laser in the other eye, decent amount of laser in the right eye, but over the course of 8 weeks, rapidly progressed to a Mac off TRD. So it's kind of thinking, oh, should we have gone in the moment that we had seen that pre-retinal hemorrhage, even though he didn't really have any membranes affecting the macula.
Was the pre-retinal, it was one of these subhyaloid hemorrhages in front of the macula,
No. So it was actually outside of the macula.
outside the macula?
Yeah. So we started PRP, but over the course of 2 months, he just rapidly progressed to a pretty bad Mac off TRD.
It's like that picture Maria Berico showed on this paper.
Yeah.
So something along that line, just
Something along those lines. Exactly.
Well, I have tremendous respect for Dr. Baracol. She's an outstanding surgeon. I think she may be the top surgeon in the world right now for diabetic vitrectomy. Her techniques of using small gauge vitrectomy, she's the one who really described the technique of doing pretty much the whole dissection with a small gauge vitrector. And she's absolutely terrific. But I think this has to be taken with a grain of salt. I think, yes, there are cases that probably would do better with early vitrectomy, but I'd say there's other cases that probably would not. And unfortunately, we're probably not going to get a randomized controlled clinical trial on this. So we're all just going to have to use our judgment on this. I think maybe going a little earlier than we might have in the past, but I still don't think, I think she generalized a little too much on this. That's my feeling.
I'm not understanding in terms of early vitrectomy for what kind of cases. Are we talking about a vitreous hemorrhage, poor vision, or like 20/20 kind of cases?
I think she's probably talking about eyes that are starting to get these pre-retinal hemorrhages. I've always thought that in a young diabetic with a lot of proliferative disease, if they get a large pre-retinal hemorrhage, that it's probably an indication for vitrectomy. But they often get these smaller pre-retinal hemorrhages, and they often do great with just PRP. So aggressive PRP. So I think you have to just use clinical judgment on these, on whether they look like they're going to progress or not.
One thing that kind of drives my opinion is sometimes you're working on these, horrendo, tractional detachment. You're like, man, I wish I saw them like months earlier, or someone operated on them, like, when it wasn't here, that, it wasn't that bad. Sometimes that drives me, but a lot of times I feel like sometimes it may be a blessing that they had an early bleed that hurts, that's bothering their vision, that they wanted surgery. A lot of times they're like 20/20 or 20/30 with bad detachment around the center, but the center is okay. And for those, it's hard to justify surgery.
Well, on those where they've already detached around the macula and the center of the macula is still on, I strongly feel that you ought to wait till they know they need surgery, because the likelihood, even if everything goes great, they may not see as well as preoperatively. We saw a lady just the other day, Melody Williams, who I've been following for probably 7 to 8 years or longer, she actually has a traction regmatogenous retinal detachment, and the macula has stayed on now for years. She's 20/30. And I'm loath to proceed on her. I mean, if she starts pulling her macula off, you got to go in immediately. I'd say within the same week, but and that's what she'll do. She'll come in if she starts getting worse.
All right, let's go to Caesar.
Sure. So the article that I'll be going over is Serene and Lipid Metabolism in Macular Disease and Peripheral Neuropathy. So this is an interesting article. The seminal paper where this is kind of all originating from, I believe, was in 2017. It was a GWAS study in Mac Tel patients where they discovered some genes that had mutations that involved serine metabolism. So the authors of this paper tried to link two separate conditions, Mac Tel type 2 and also hereditary and sensory autonomic neuropathy type 1, HSAN1, which are both thought to have this underlying common cause of disease, which is low serum level. So Mac Tel is a low prevalence, about 0.06% in the population, happens in the 5th or 6th decade of life. Patients with Mac Tel type 2, patients with HSAN are found to have genetic mutations in one of two genes encoding for subunits of this enzyme called SPT, which stands for serine palmitoyl transferase. So SPT condenses both serine and palmitoyl CoA. It's a rate-limiting enzyme in the sphingolipid synthesis. Mutations in this in these two genes that encode for SPT cause an increase in deoxysphingolipids, and that's thought to be the cause for this disease, HSAN1. So when serine is low, SPT then uses alanine to create deoxysphingonine. And so deoxysphingolipids, there's been a lot of literature, and it's been shown that they're toxic to multiple cell types, especially neurons. And the thought is if you can determine that there is a pathway here that is connected, you can find the offending agent, potentially you can have a therapy for Mac Tel. So enrolled patients were Mac Tel type 2, HSAN1 patients, patients who had both family members and unaffected controls. This article is broken down into several different parts, which I thought was interesting as well. So we'll go over in little bits. So all patients were examined with exome sequencing, DFEs. They had Heidelberg confocal imaging, dual wavelength autofluorescence, and fluorescence lifetime imaging ophthalmoscopy, which is a prototype instrument of Heidelberg. And the clinical diagnosis of Mac Tel was confirmed by a separate retina specialists, two of them at Moorfields Reading Center. So for the first part, they looked at HSAN1 mutations and tried to figure out whether or not it was the same mutations were causal for Mac Tel type 2. So they had 13 patients with HSAN1 that were evaluated. 11 of them carried the SPTLC1 mutation, and 2 of them had the SPTLC2 mutations. Mac Tel was observed surprisingly in 9 of 13 of those patients. And 4 of them, even though they did not have Mac Tel, they did have abnormal macular features and Mac Tel phenotypic changes, but the authors didn't go into detail what changes they were. The authors also noted that they were younger than 50 and were possibly too young to have developed Mac Tel in its full phenotype. Interestingly enough, this prototype FLIO was positive in the majority of the Mac Tel diagnoses that they had. The second part, so even though that most Mac Tel patients do not have this SPT mutation, they do have low serine levels, and that's been described. Under low serine, like we mentioned, alanine is incorporated, and this results in the creation of deoxysphingolipids, specifically deoxysphingonine. And the goal was to try and determine whether they're elevated in Mac Tel patients. So they assayed amino acids and sphingoid bases in specimens from 125 unrelated patients, 94 unaffected controls. None of these patients had SPT mutations to begin with, and that was confirmed genetically. Deoxysphinganine was found to be higher in 84.2% of patients with Mac Tel type 2, and that was statistically significant. To follow up on this, the thought was whether there's any relevancy to these higher levels and if there's any correlation to structural damage. And they did find that there was a positive relationship between ellipsoid zone loss on OCT and elevated deoxysphinganine levels in these 125 patients with Mac Tel. Separately, relevant findings related to these levels, it's been reported that diabetic patients have had high deoxysphinganine levels, but that's not what they found in this study. And the thought was that these peripheral neuropathies that are seen in these other conditions with low serine levels may be one of the reasons why diabetics have a neuropathy, but that was not seen in this study. Consistent with previous findings, so serine levels were definitely lower in the Mac Tel patients, about 20.6% lower on average. And the deoxysphinganine did show moderate correlations with plasma serine and alanine, which is seen in figure 2. So the fact that deoxysphinganine levels were similar in Mac Tel type 2 patients at HSANT1, and it may indicate that low serine is sufficient enough to cause this disease-associated increase in these levels. The next part was mouse models. So they depleted the mice, male mice, 8-week-old mice, of serine and glycine. The reason they use glycine is because glycine can be converted into serine as well. So they depleted them of both. And in these mice, after several weeks, the serum RPE and retinal deoxysphinganine was higher compared to control mice. Similar findings were found in the sciatic nerve. And when they did ERG measurements, it showed a deficit in photopic and flicker responses. All indicated that elevated deoxysphinganine causes functional deficit, at least based on the ERG and based on the higher levels in the sciatic nerve as a cause for peripheral sensory deficit as well. So we saw the structural changes as seen with higher levels, but the question is also whether or not they have any functional damage. And we know in Mac Tel, late findings are loss of photoreceptors. So the authors used human-induced pluripotent stem cell retinal organoids. And these retinal organoids contain the majority of most major retinal cell types, including photoreceptors and Mueller cells. And they treated them with these deoxysphinganine levels, similar to what's found in serum of the Mac Tel patients. And it caused apoptosis in a dose-dependent manner, which was interesting. They also had a suspicion that there was a downstream byproduct of this deoxysphinganine that was actually the main cause of this toxicity. So they used fumonisin B1 to inhibit one of the downstream enzymes, which is ceramide synthase. And using this enzyme actually prevented cell death in a majority of these retinal organoids, which was interesting. The effects of deoxydihydroceramide can also be decreased with a PPAR alpha agonist like fenofibrate, which is commonly used to help patients who have dyslipidemia. So so what they did is they used these organoids and then they administered the fenofibrate, and that reduced deoxysphinganine cell death by 80%, which was pretty significant. So overall, the authors were able to link these two seemingly unrelated diseases that may have an underlying similar mechanism of pathology, using a lot of different ways of studying, using metabolomic assays and serum assays, genetic analysis, and mouse models. So I thought it was very interesting. And so far, from my research that I've looked up, I haven't seen anybody actually try to put this into practice or use supplementation of either serine or fenofibrate in Mac Tel type patients. But I think down the road, that would be something to try.
Well, there is a randomized controlled clinical trial that's been going on
Oh, in progress.
well,
Neurotrophic,
it's in the patients with HSAN1. And they found some improvement in these patients. It was a small trial. And it was a 2-year trial. The first year they were randomized. The second year they did crossover, and everybody was on the Serene supplementation. They were fairly high, 400 milligrams a day. And they did show benefits. So, we've got, Jane had found this, and I think it's just the abstract that we have. We don't have the full paper.
Yeah. And it's actually the 13 HSAN patients in this paper most of them were already on Serene supplementation. So it is something that providers are doing.
Yeah. So, but I think this is fascinating. I mean, I remember we've been seeing Mac Tel for, I don't know when it was first described, but we've been seeing it since the 70s, early 80s probably. And, we had no clue what was causing it. And I think that, Cesar, I think the first idea that this was related to the Serene was when they actually they found Mac Tel in some of these patients that had this HSAN1. And that was the tip off that there might be. And then they started looking at them, and that's when they went in and started looking at the Mac Tel patients and seeing if any of them had similar findings. So I think it was not the GWAS study. I think that came later. I think the first was a clinical observation that some patients with HSAN1 had Mac Tel. And some smart person asked the question, wow, are these related? Yeah. And, that's the way things happen. I think is a wonderful observation that's really led to some major findings. I think this may become a treatable disease. That would be wonderful.
Yeah. And the genes actually that they found in the GWAS study were different than HSAN. So it'd be interesting to look into those as well. Yeah, they were actually separate genes.
Yeah. So, and then in the Mac Tel patients, they did not usually find, most of the Mac Tel patients, they did find abnormal serine levels and the increased deoxysphingoline levels, elevated deoxysphingoline levels, but most of the Mac Tel patients, they did not find the same genetic abnormality. A few of them they did, but most of them they didn't. Am I correct?
So there must be yes, that's correct.
Yeah.
Yeah. So there's another reason why these Mac Tel patients have low serine that has yet to be discovered.
They don't know why, but they do have low serine levels. So.
Yeah.
So the thought is, so just to clarify, so when you have low serine, you have more of that alanine to plus palmitoyl-CoA pathway.
Increased
deoxysphingoline.
Yeah.
Because the palmitoyl-CoA will be attached to alanine, but we'll go work with down that alanine pathway more.
The alanine pathway, exactly.
Okay.
Yeah.
Right.
Okay.
Yeah, and the thought is that deoxysphingoline and its byproducts are the cause of these toxic effects. Yeah.
Okay.
But I think this is absolutely wonderful paper. I just think it's incredibly exciting to finally get into the molecular and biochemical basis of disease that we've been seeing for years and had no idea what was causing it. I just think it's wonderful.
Yeah, they were able to demonstrate so much in in one paper. So it was really nice.
Yeah, I mean, absolutely phenomenal paper. So anyway, thanks for such a nice review of that paper. I think all of you did a wonderful job on these papers. Right? They're just great. Do we have any more?
Yeah, I think we have 2 more.
Okay.
Yeah, I have each have papers.
Do you want to go first, Ryan, or do you want me to go first?
I can go first. It doesn't matter.
Go for it.
Okay, so the paper I was doing, it's titled basically, sorry, let me just pull it up. Recurrent Neovascular Age-Related Macular Degeneration after discontinuation of VEGF inhibitors managed in a treat and extend regimen by Aslanis and et al. So basically in this study, they were kind of focusing on, their purpose was to basically investigate the recurrence rate of active macular neovascularization in patients with NAMD, previously followed up in a treat and extend regimen in which treatment had been stopped because of disease stability. The whole reason they wanted to look into this was just that the volume of intravitreal injections in retina practice has been increasing. And I guess there isn't a definite kind of exit strategy to how to kind of taper the patients off kind of indefinitely. So what they ended up doing was they looked at patients who basically had NAMD and were treated at diagnosis with 3 monthly aflibercept injections and were subsequently followed up in a treat and extend regimen with extensions of 2 weeks at a time if there was no disease activity. And patients reaching 12-week intervals without any disease activity on 3 consecutive visits basically were eligible for inclusion. And then they had some, I guess, best corrected visual acuity, inclusion criteria that they had to be between 35 and 88 letters or a Snellen equivalent of 2200. So basically, to standardize or keep everyone on the same page, they ended up giving everyone an extra injection at kind of when they were enrolled in the study, and then they followed them up 4 months later, and then after 4 months, they followed them at 2-month intervals until they reached 12 months from that last injection they gave. So they ended up finding 105 patients that were eligible and included in the study. 3 ended up passing away. There was a female predominance, which was consistent with AMD, and that there was 73 out of the 102 were women. And then they found a recurrence rate of about 53%, 54 of the 102 patients, and that was at the end of 1 year, that recurrence rate. So in the mean time to recurrence was about 7 months after the last injection. So then they looked at, did the visual acuity change upon recurrence? And basically those with recurrence had no significant changes in vision. There was kind of like a trend to decreased vision. And then basically when they started treatment again, that trend kind of went away and it became basically equivalent from baseline. When they looked at people who had symptoms, so of those recurring, only about 41% had visual symptoms of worsening vision. And of those, there was a significant decrease in vision, but not by a lot. It went from a baseline of about 73 ETDRS letters to 66 letters. And then as soon as they started treatment again, basically the vision improved to back to baseline. And again, they looked at central retinal thickness, which basically increased with recurrence, but then decreased, and it had increased significantly with recurrence, but then decreased again back to baseline once anti-VEGF was reinstated. So importantly, they did find that pigment epithelial detachments at baseline were associated with a higher recurrence rate. So that group, there was about 19 patients with PEDs and 74% of them recurred. whereas patients without a PED had a 48% recurrence rate. They also looked at geographic atrophy and the type of CNV that they had, and they found that those didn't really play a role in I guess, recurrence rates. In their study, they had kind of significantly more type 3 macular neovascularization, I think, than kind of in general, and they kind of attributed that to that maybe type 3 CNV just kind of responds well to a treat and extend regimen. They also looked at they classified some patients as rapid responders, which was basically before the study even started, that those patients who, when they were basically started on anti-VEGF injections, that they were able to be extended to 12 weeks without any recurrences. So in that group they got about 8 injections before the study started. And again, the rapid responders versus those people that had recurrences in the past, it also wasn't a significant factor or significant association with recurrence. So basically their conclusion was that if they had, for the patients in their study, if you had just continued the 12-week intervals, almost half of patients would have been overtreated with that treat and extend regimen. So they were kind of saying that it's still a little unclear, I guess, how to kind of, space the injections out without overtreating patients, but also not missing patients that are recurring, that might kind of have permanent vision loss if you don't treat them again quick enough. And then they were also saying that pigment epithelial detachments may indicate more active disease.
What do people do when you have these wet AMD that they're dry every 3-4 months, and you haven't seen any reaccumulation for a couple of visits, like 6 months or more? Do you do any? Do you try to extend it more? Do you try to extend it 4 months, or just keep treating and extending? Or at some point do you stop, or do you do what they do and do PRN?
Well, CC, I don't know the right thing to do, but I keep them at 12 weeks. And I'm always worried that the ones I miss or they don't come back, they get worse usually when I see them when they have the recurrences. But the ones I'm really fearful of are the ones on anticoagulation. So those absolutely keep them on a 10-week, 8 to 10 week schedule no matter what. I will just continue to treat them.
Kind of COVID showed us some of the natural history when these you had these every 2-3 months, and then with COVID they naturally had a long extension, and some of them do come back with a bleed or a significant recurrence.
I've got some patients that I've gotten out to 6 months, or I had one patient I was doing him about every 8 months, but he finally had a little recurrence, and I went back to 6 months, and he's coming in every 6 months, and I'm injecting him. But that's unusual. It seems like most of the time you got to get them earlier. I thought it was interesting in this one that I think that one of the keys in this was even after they stopped injecting, they had 4 months twice, extended to 4 months 2 times in a row. And I'm getting some feedback from Jane's computer, I think. Is that bothering? I hear it. Hopefully you don't. But anyway, they had 4 months 2 times in a row. Then they stopped injecting. But I think the key is that they were following them every 2 months. And I think that's the key. If you're going to extend them, you need to, if you're going to stop injecting, you better keep following them closely every couple of months. And it was really interesting. They had very good visual results if they treated them when they saw a recurrence. So that flies, sort of that most people, there's a lot, it's pretty much thought by many, many people that, you're going to get vision loss with any recurrence, but that's obviously not always the case.
But Gary, that can be the case, especially in these one-eyed
Sure can.
people.
Absolutely.
Right. And
Get a
so
big-
my
big
concern,
recurrence. If you get a
you get
big
a big
recurrence,
recurrence in a one-eyed person, you're just toast, and you get a hemorrhage in those people. There's nothing you can do. So anyway,
Dr. Abrams, do you
right. I mean,
ever
if they
stop?
hemorrhage, it's all she wrote.
Do you ever stop injection besides if they have horrible vision? I mean, say if they have, counting fingers, big.
oh sure,
scars.
those people don't.
Yeah.
Those people don't need to be treated, but those people who've got 20/70 vision, 20/60 vision.
Yeah.
I mean, in my experience, if they have a recurrence, they lose 2 lines in vision, and it's traumatic for them.
Yeah, I think you're right.
When you have those big scars, if they keep bleeding at the edge of the scar and then get a new scar, do you continue to treat them, or?
No, I actually don't. If it's a big scar and it's a
Okay.
bad vision, because that's the natural history of the disease, that most of them are going to get extension. Now, if it's their only eye and they're relying on their visual field, I do. I will treat them if it's the only eye in the visual field and they get a hemorrhage. I'll treat them once or twice, and I may be treating just me, but most of the time, I just treat
Well,
people with definable vision.
If
What
they
do you
get
do, Gary?
hemorrhage, I think it's a different ballgame if they have hemorrhage. I think you ought to
Yeah.
treat them. Even with a disciform scar, if they get a hemorrhage, I think you ought to treat it, because if they get a big hemorrhage, one of these massive macular hemorrhages that goes equator to equator, which sometimes they'll do. And it's been shown that what happens is when you've got a disciform scar like this that hemorrhages, you're literally blowing out an artery. So you got blood you've got blood in the eye at arterial pressure, and it can be quite extensive. So if I see blood, I start treating these patients until the blood's gone, and then I'll continue. Then I'll go back to following them again, unless they get more hemorrhage.
Great discussions. Last one. Hassan.
Yep. So my paper was titled Efficacy and Safety of Biosimilar FYB or FIB 201 compared with ranibizumab and neovascular age-related macular degeneration. So this study essentially attempts to demonstrate FIB 201's clinical equivalence to ranibizumab. The drug itself is a biosimilar agent of ranibizumab, and the reason for using this new drug would be to lower costs to patients that previously had been receiving ranibizumab injections. So it was a masked 48-week randomized phase 3 study looking at FIB 201's clinical equivalence to ranibizumab in terms of its pharmacology, efficacy, and safety for patients with treatment-naive neovascular AMD. Just briefly, some of the inclusion criteria: patients were either male or postpartum females, all aged over 50 years of age. Again, had to be newly diagnosed. Yes. Sorry, I thought I heard a comment. Patients had to be newly diagnosed with neovascular AMD and be treatment naive. Patients, other inclusion criteria included subfoveal or juxtafoveal choroidal neovascularization with foveal leakage related to CNV activity, retinal thickness over 350 microns, CNV area over 50% of total lesion area based on FA and then confirmed by an outside reading center, or vision between 2032 and 2100 in the study eye, and then better than or equal to 2100 in the fellow eye. And then quickly, some exclusion criteria: having undergone prior intravitreal injections, prior vitrectomies, macular surgery, history of intravitreal corticosteroid therapy, or intravitreal implantable device within 6 months before screening in the study eye. Of note, all subtypes of CNV found in neovascular AMD were included in the study. The primary endpoint for the study was change in baseline best corrected visual acuity at 8 weeks, but prior to receiving their third intravitreal injection. So after having received 2 injections. Secondary endpoints included change in best corrected visual acuity at 48 weeks, change in the foveal central point thickness at 48 weeks, proportion of patients with active CNV leakage at 48 weeks, proportion of patients with a fluid-free macula during the study, and then change from baseline in total lesion area at 48 weeks. Some other endpoints they looked at were safety of both drugs, and then the systemic concentration of the drugs as well. So 477 patients were randomized and treated. Ultimately, 226 patients made it through the treatment group and 226 through the control or ranibizumab group. Table 1 goes over the demographic characteristics of both groups. Ultimately, there were no significant differences in their demographic characteristics. And then table 2 demonstrates, their primary endpoint, the best corrected visual acuity at 8 weeks. So there was a mean change of 5.1 letters in the FIB-201 group, and a mean change of an improvement of 5.6 letters in the ranibizumab group at 6 weeks post-enrollment. So the difference in the change of letters between the two groups was statistically insignificant in all their methods of analysis. There was a mean change of roughly 8 letters in the treatment group and 8 letters in the control group at 8 weeks post-enrollment as well. I'm sorry, 48 at the end of the study, not 8 weeks. So there was roughly 8-letter improvement in both groups at the end of the study. Regarding foveal central point thickness, there was a decrease in just over 200 microns in both groups. Again, statistically insignificant, and this endpoint was at 48 weeks. That's demonstrated in figure 3A. And then regarding CNV leakage at 48 weeks, the percentage of patients with leakage was similar between the two groups as well. And then a couple more results that I thought were important was the systemic concentration of both drugs were found to be similar. They were measured at 24 weeks and 48 weeks. So similar at 24 weeks, however, they did find slightly higher concentration in the FYB-201 group at 48 weeks. However, the sample sizes were pretty small in both groups. Only 26 patients in the treatment group and 30 patients, or in the FIB-201 group, and 30 patients in the ranibizumab group. And then regarding adverse events, there were no significant differences between the two groups. They do mention a few patients in both groups had discontinued treatment. However, most of them were not related to the drugs themselves. There was only one patient in the FYB-201 group who had worsening of their AMD, who had to be discontinued in the study. And then finally, the immunogenicity to the drugs in both groups were similar. Both groups had 14 patients who developed antibodies to the drugs. And then finally, the study was also carried out in the EU with similar results. They didn't mention anything, they didn't mention any results that had differed between the US population. So in the discussion, they go over the results again, and then they make the point that biosimilars tend to lower the price of the biosimilar drugs as well as their related pharmaceutical products, which in turn increases the ease of access to these drugs. I think that's good in theory, that would work, but with Avastin being used so frequently for AMD and being such a cheap option, I don't know, how much this would make a difference. I guess it would depend on how frequently ranibizumab or Lucentis is used in practice. And I don't know the numbers just because, we use Avastin here and Eylea at the VA. So,
I mean, the Lucentis, I think, what was it, 2 years ago or 3 years ago, that the patent ran out for Lucentis. So, the non-biologic molecules, then you make generics, and the biosimilar, because these are, created from the antibody body, these biologics are created by, through animals and things like that, then it's the biosimilars. It's not technically called a generic, but basically they're sort of the same thing. Dr. Abrams, does FDA require you for biosimilar? You need to do a small clinical trial, right? But you have to do, it's different than a generic where you can just sort of, as long as you show it's the same thing. The biosimilar, you have to do like a small trial similar to this.
Yeah. I don't know the exact rules on it. I really don't.
I thought the active ingredient had to be the same, but the other components could be different.
I thought that was
That's
for
what I had read.
Is that for biosimilar or if that's for generic? But I thought the biosimilar, you actually have to do something like this, like a small, like 300 people trial to show that it's actually, because it's hard to control the way they make it, if it's like grown like from a mice or I forgot what you said. Made it like what animal is used to make the Lucentis, that because it's through biologic, that it's not just something you can put chemicals together and make the compound. You have to grow it through these these organisms.
Yeah, that's made from E. coli, I think, isn't it?
Is it?
That's what it said. E. coli.
Yeah, that's what it said.
I'm confusing it with my Humira. But anyways, that I think you have to do it this way. But there's some estimate.
Oh, sorry.
Okay.
Can you mute? I'm sorry.
Turn yours on. Mute yours completely.
Oh, I muted.
I think Jane is muted. I think everyone's muted.
I think they're trying to, there we go. I think she unmuted herself.
Okay.
But actually, sorry, I think you're right, Dr. Lin, what you were saying about them. That's what I'm reading right now.
Are you muted totally?
I could hear you well normally now. I think both Jane and Dr. Abrams are muted.
Yes.
I think both are unmuted now.
But we had some feedback and I closed my computer and I had to sign back on.
The industry people are estimating this to be roughly half the price of Lucentis. Maybe half, maybe 40%. It's not like the same price range as your Avastin.
Would you see that making a big difference then? Or, not really? Is this, I guess what would be the point of coming out with this drug then, right?
Yeah, Hassan, some people, there's a lot of docs who just don't like to use, anything made by the pharmacies, that they want
Fair.
they want a FDA approved drug. And so if this is available at a cheaper cost, I think there'll be quite a few people who will go to it.
And Gary, there is a medical legal issue to that, right?
Well, I don't think realistically there really is anymore. I think at one time there was. I don't think so anymore. Avastin is, Medicare require, the insurers require you to give Avastin. There's, it's so commonly used that I don't think there's any issue in medical legally in using Avastin anymore.
No, I don't disagree with you. I'm just bringing up the point that it's out there.
Oh, yeah.
The other biosimilar that is that they're doing a little clinical trial. It's a biosimilar of Avastin for basically for AMD. They're so basically doing a biosimilar of Avastin for FDA approval for use for AMD.
Oh, that would be good. Of
Yeah,
course,
but then
they'll probably charge
a lot
10
more
times
for it.
as much as
Yeah.
as we pay for Avastin.
I think that the estimate is 20 times.
20 times, okay.
Yeah, around 500 per
Yeah.
per shot.
So,
Would that then force people to move over for legal issues, I guess, since now you
No.
have the same drug, but it's
no,
FDA approved?
I don't think so.
Yeah, I'm not sure, but the current landscape, because Eylea has another 2 more years before the patent runs out.
Right. So you'd have to dicker with it in a court of law. But on the other hand, Lucentis has this such a great binding capacity. It's just so intriguing that it could work so much better. That's all.
I mean, for AMD, not necessarily, but for some disease state, it seems like if you fail Avastin, the Lucentis or Eylea do better. I mean, that would be one of your arguments for actually using the biosimilar.
Well, it'll be interesting. Probably it's going to take them a while to get it to the FDA, and then it'll be probably approved. Be a couple of years probably before it's approved.
Oh, the process is actually a lot easier for the biosimilar. They require just basically a small study, and then they as long as it basically seems to work the same, and
it's safe. Yeah.
Yeah, and then they usually just do it. It seems like it's a much short, abbreviated process.
Yeah. They were pointing out in this article, they were pointing out all the other biosimilars that are out there, like Humira and some of those that they're now biosimilars for. So.
I mean, there's another medication no one really uses much, but you can actually order it. It's the Ziffa aflibercept. Basically, yeah, the compounding pharmacies actually make it. And it's much cheaper than I mean, it's basically a aflibercept for cancer that, because the compound pharmacy made it into small portions.
Well, it's used commonly in some countries. That's used very commonly. But I think very few people have used it here, but certainly in some other countries, it's become pretty common.
I don't think you can get a pay for easily either.
Yeah. All righty.
All right. Yeah. Well, thanks for
great job, everybody.
Thanks for all the articles, everyone.
Thank you.
Okay. All right. Good night, everyone.
Good night.
Good night, everybody.